So welcome everybody. I'm Ken Knapp, the director of the Center for Long-Term Care, School of Health Sciences and Practice at New York Medical College. And welcome to our webinar. It's a panel on hospital at home programs with Ronnie Snyder, Carol Levine, and Imran Ali, who I'll introduce in a minute. First, I just want to thank some people who've helped make these webinars possible. Thanks a lot to Cindy Jakubowski, who's Administrative Secretary of the Department of Public Health, Stefano Bonanni, who's Administrative Director of Operations in the School of Health Sciences and Practice Dean's Office, MPH GA, Sylvia Bandia, and Lana Bedas, and DRPHRA Jay Ayar, Michael Frankfurter in Educational Media Services, the Center for Long-Term Care Advisory Board, Susan Fox, our very own Carol Levine, Melissa Lang, and Michael Majax, the chair of the Department of Public Health, Mark Kittleson, the School of Health Sciences Dean, Rob Amler, and Vice Dean, Ben Johnson. So thank you all for all your support. And the center will host another webinar on November 3rd by Aaron Bolden, who's going to talk about a longitudinal data set about caregivers. So you'll receive information about that. So now I'd just like to introduce our terrific speakers. We have a fantastic lineup. Ronnie Snyder is Vice President Program at the John A. Hartford Foundation. She has over 25 years of experience working with preeminent healthcare institutions across the nation, improving the care of older adults, identifying and guiding healthcare programs that have set the standard for medical best practices, increasing medical education opportunities, and maximizing resources to improve healthcare broadly. Imran Ali is a physician fellow in palliative care, geriatric supportive oncology training at New York City VA System Icahn School of Medicine at Mount Sinai. He previously was at the University of Connecticut Center on Aging with a special focus on geriatric oncology. He completed his residency in the Department of Internal Medicine at Bridgeport Hospital, Yale in New Haven Health. And he's currently a contributor to the Walt Disney Television's ABC News Medical Unit, which covers such things as Good Morning America and World News Tonight. And he is an alumni of our MPH program. He's also, I'm proud to say, a current DRPH student. Carol Levine is a senior fellow of the United Hospital Fund and a writer, researcher, and consultant in family caregiving and health policy. Her previous positions include Director of the United Hospital Fund's Families and Healthcare Project and Director of the New York City Citizens Commission on AIDS. Ms. Levine was awarded a MacArthur Foundation Fellowship for her work in AIDS policy and ethics in 1993. So it's a really great lineup, and I thank you all, Ronnie and Carol and Imran, for taking the time to do this. The title of the presentation is Back to the Future, 3 Views of Hospital at Home Programs. And first, just a couple things. Let's all please mute ourselves unless we're the ones doing the talking. And also let's silence our phones. And let's wait until the end. We have 3 speakers. We have a dead stop at 6:15. So once all 3 speakers are done, unless you have a question that needs clarification while they're talking, I don't think they'll mind if you ask that at that moment. But if you have a question, just click the little hand raise icon or send a chat, and we'll try to get to you in the order received. So thank you all very much. And now Ronnie Snyder is going to open it up.
Thanks, Ken. That was a lovely introduction. Okay, here's me when it was a little bit warmer, apparently, because I'm not sleeveless today. So actually, give me a second. I'm going to fix my screen so that I am not looking at things blocking my screen. Thank you. All right. I love the title of, of this. Thank you, Carol, for coming up with our Back to the Future title. If you'll take me to the next slide, please. I'm just going to give you a couple of sort of introductory remarks about the John A. Hartford Foundation. I'm still seeing the first slide. Shall I just keep going? Oh, there we go. All right. Thank you, Jay. So we are a private philanthropy. We work nationally, although we're based here in New York City, and we were established by the owners of the great Atlantic and Pacific Tea Company, who you may know as A&P Groceries. And at this point in time, we have funded, gosh, at least $640 million in grants since the launch of our Aging and Health program in 1982. So we've existed for much longer, but this is just the Aging and Health timeline. And we've really invested those funds over time in building the field of experts in aging, and that includes especially physicians and nurses and social workers, but others as well, and in testing and replicating innovations in healthcare. And that's what we're here to talk about today. Next slide, please. So we do that now through our three priority areas. So building age-friendly health systems, supporting family caregivers, and improving serious illness and end of life. And we like to think that many of our programs, and certainly Hospital at Home is one of those, speaks to all three of these. These are, as you can see and hear, not siloed areas. They are very much overlapping, and that's by intention to get to our mission, which is to improve the care of older adults. Next slide, please. So Hospital at Home, that's what we're here to talk about today. And so what is it? Hospital at Home is acute hospital level care for older people and others as well, where they live, rather than in the traditional hospital setting. So it includes things like daily nursing visits, oversight by physicians or nurse practitioners, providers on call 24/7, that would be consistent with hospital level care. And a typical program includes a combination of in-person visits as well as possibly video visits and some telehealth monitoring. And it includes things that you might not think of as being services at home, like oxygen therapy.
type of meeting ID છે?
I'm going to keep going. Oxygen therapy, intravenous fluids, and antibiotics.
શરૂ થઈ ગયું.
Be administered at home. Is it possible to mute someone?
Got him.
Yep, it muted me too. Okay, I'm back. Okay, so this program started with 5 different clinical conditions. Now we're at more like 100. Oh gosh. Next slide, please. Okay, so there have been programs in numerous countries. And just a little bit of history about the Hospital at Home program. The Hospital at Home model came in the US, the program in the US dates back to 1995. And it was the brainchild of a longstanding friend and mentor of mine, John Burton, who's a physician and the former director of geriatric medicine and gerontology at Johns Hopkins, and a program staff member of the John A. Hartford Foundation, Donna Regenstrief. So doctors Burton and Regenstrief envisioned a model to provide really safe and effective hospital care at home. So there was a team of geriatric researchers led by Bruce Lepp, who's also a longstanding champion of this work. And they developed the basic clinical model and its patient eligibility criteria. So then from 1996 to 1988, they conducted a 17-patient pilot trial to prove the model's safety and feasibility, which was followed by a national study at 3 different Medicare managed care organizations and a Veterans Health Affairs hospital from the years 2000 to 2002. So you can kind of see the progression over time. And it was all about further assessing the program's safety and its benefits, And the latter of those really marked the first time that the model itself was fully implemented as a replacement for hospital care, according to Johns Hopkins. So we've continued to fund this. In 2004, we provided a 6-year grant for greater dissemination. 6 Veterans Affairs medical centers implemented the program in 2009. At that point, the project shifted to a licensing and consultation model to support the spread of the model. So in 2011, Johns Hopkins helped start the healthcare startup called Clinically Home to develop its own home-based care model, which really relies more heavily on telemedicine than the original model did. So there's lots of variations on this work now. Again, we've continued to support that with later a 4-year grant in 2014 to augment the federal evaluation of the hospital at home healthcare model. And the point of that evaluation was to lay the groundwork for widespread dissemination, because you've got to have the data before the feds and others really are going to be willing to think about dissemination. So in 2017, we funded another expansion project called Rehabilitation at Home. This is yet another sort of takeoff on the model. And we have continued to authorize grants all the way through 2018 and 2020, where our latest grant is really to support the policy work and further dissemination. Next slide, please. So this slide and several others come from Bruce Leff, who I mentioned before, who's one of the original physicians and a great champion of the program. It's really about, why do we need this? Who wants hospital at home? And so this is a real patient of Bruce's. This is Walter, and he doesn't like hospitals, surprisingly enough. Don't we all love being in hospitals? And some of the comments that he made were, I can't get breathing treatments on time, so I end up on a ventilator, and that is miserable. He says the food stinks, which oftentimes it does. And he says, no one talks to me. So for all of these reasons and more, he said, I got confused. That's delirium, right? And tied down. Those are restraints. And I always come home with a completely new set of medicines, which is confusing and adds complication. So we'll come back to Walter, but next slide, please. So in the interim, we're thinking about Walter, we're thinking about him at home. There have been many, many different clinical trials. And this is a little bit of information about why it's worthwhile to give people the care that they prefer at home. There's a selection process, by the way, for what kind of patient gets care at home. But the outcomes have been consistently strong, and you can see here what some of those outcomes are, and that there have been just dozens of randomized controlled trials. So I won't read all of them because you can see them here, but these are quite meaningful measures. Next slide, please. Okay, this next slide is an older slide with now out-of-date numbers in terms of the numbers of people served. But the value of this slide is in illustrating the continuum of home-based care options. So again, please note, this is pre-COVID data, so the numbers are really different now. But I want to note that, there's very low acuity care that happens at home. There are, of course, informal services. There are more formal personal care services. There is skilled home health care that we hear about. And there's also a real focus right now on home-based primary care, which is physician or nurse practitioner level care in the home, but it's not acute care. And then there's hospital at home. This is the highest acuity. These are the most acutely ill patients. And it has the highest level of physician or other advanced provider involvement. So next slide, please. Okay, now Walter came home. So this is what Walter thought of his experience with hospital home. He said, I definitely would have ended up on a breathing machine if I had been in a hospital. We see this all the time. He said it was so great to get the attention from nurses and to have the doctor see me at home. And not unimportantly, he said, I didn't have to worry about my cat. I mean, these are real world concerns for people who sometimes live alone, not always, but it is a concern for people when you take them out of their home environment, and it affects what matters to people in so many ways. Next slide, please. Okay, so I'm going to talk a little bit about policy and advocacy for hospital at home. So I'm shifting a little bit. COVID hit, and since that time, there has been rapid expansion of hospital at home. So one big development was a rapid expansion because of the pandemic, and it includes tech-enabled processes, right? So home became the safer and more preferred setting for sure. And the expansion is possible due to things like communications technology, portable
Yes, have a
medical
good night.
equipment, and teams of doctors, of nurses, of X-ray technicians, and paramedics as well. So in addition, a public health emergency was declared. I mean, this is not news to anyone, but this has very much affected the numbers for this program. So in November of 2020, so just about a year ago, CMS launched the Acute Hospital Care at Home program, which allows approved providers the flexibility to provide acute medical services at home. And more than 90 hospitals have joined the waiver program. And I'll give you some specific numbers in a minute. 6 health systems began immediately participating in the program. And now startup companies are beginning to offer logistical support and technology to facilitate hospital at home programs, while also helping to contract with commercial payers. So next slide, please. Okay, here we are. This is the waiver program that I mentioned. It allows approved providers the flexibility to provide acute medical services at home during the public health emergency. And the big news is I actually have an update. So you've got numbers here from the end of September. I've got adjusted numbers from about 2 weeks ago. 77 systems, 177 hospitals in 33 states obtained approval. So there's a users group right now that to help new users and to share information about best practices for the people who have been working on or are interested in working in this area. And I'll tell you a little bit more about that in a minute. But there are conversations right now with CMS about continuing this post-pandemic. It's as yet undetermined. And we don't expect anything to change on this note until the end of the year. Next slide, please. In the meantime, hospital at home has indeed taken off. These are all news articles after March 2020. And these don't include the 2 from last week that my staff sent me, knowing that I was going to be having this conversation. And if there's 2 a week for however many weeks, this is garnering a great deal of attention. Next slide, please. So this is my last substantive slide. And I just want to say, the current work that the Johnny Hartford Foundation is doing is really about scaling and dissemination of the hospital at home program during this time and beyond. So part of the learning community that I talked about earlier, which really is this users group, the first bullet, is to teach people about things like billing, among others, like how to stand up a program. It's about really assisting providers to apply for the waiver. And it's about demonstrating the model as ultimately a necessary care option for COVID-19 and beyond. So, a quote from Bruce Leff is, this is a most studied model out there. If this were a drug, it would be a blockbuster. So this is a program where we know it works. And a ton of infrastructure has been put in place over the last year and longer, but particularly in the last year to support hospital at home programs. Hospital programs or hospitals across the country have spent big in moving acute care to patients' homes as COVID-19 really tested the safety and the capacity of a lot of systems to be able to care for people within their facilities. So that said, I noted before, we don't know yet what care modalities may stay post-pandemic. There was an article in Modern Healthcare just last week talking about the fact that next year, when the public health emergency ends, please tell me it's going to end next year. I've got all my fingers crossed. CMS is going to have to make some hard decisions about which models to keep versus let go. And this is about hospital at home for sure, and others as well. I mean, think about telehealth and other models. So I will stop there and pass it on to my next slide, please. Pass it on to our next speaker, but just know that we are very much in support of the work that's been done on this front, and I'd be happy to talk to folks later on.
Thank you very much,
Wow,
Ronnie.
thank you so much. That was an amazing overview of hospital at home, and you touched upon some of the things that I will talk about just from being, in the field and as a geriatrician now. I just graduated from my fellowship training, and I will be starting actually at Mount Sinai, one of the hospitals that, has adopted this hospital at home care model. And, we talk about how this hospital at home can be useful for everybody, but it especially has been beneficial for our older adult population, which is just, skyrocketing. Till 2029, we're going to see a rise in older adults in our population every single year as the baby boomer generation ages. So we learned a lot of lessons. Let me just get rid of these pictures on the side here so I can see what I'm doing. How can I diminish? There we go. Bear with me. I'm sorry. Can everybody see my slides?
Yes.
Okay, great. So the pandemic, this public health emergency that we do indeed will end next year, has taught us a lot. The hospital at home concept was around for a while, but it was not until the early days of the coronavirus pandemic is when we really saw the potential, especially for our older risk adult population. And I remember, as a pediatric fellow, but also covering the pandemic, what was happening in Italy. And we saw the onslaught of older adults in the Normandy region, get truly afflicted by COVID-19. And even in our own country here by April 2020, well, I'm talking about Italy right now, but Italy recorded close to 14,000 deaths by April 2020, just in 1 month. And most of them were in the older adult population. So I connected with many of my Italian counterparts in the Lombardy region, where most of the cases were, and the median age of the population was around 80. And they really talked about how there was a need for a decentralized approach, a way where the doctors can triage and treat patients within their homes rather than all congregating and coming to the central location of the hospital, where the worried well came and just was even more exposed to the dangers of hospital, which is taking in people with a highly infectious disease, not to mention the other risks that are inherent to hospitalization for any older adult. So a great article in the JAMA Health Forum, talked about what we can learn from Italy and the COVID-19 pandemic. And it talks about, again, this whole need to decentralize care, having people go out to the home rather than, everybody coming to one point. And they said that could have really made a difference in the numbers of people who died, especially in that very first month. And a great article also in JAMDA, the Journal of the Post-Acute and Long-Term Care Medicine, talked about how the hospital at home actually expanded hospital capacity during COVID-19, because a lot of the people who were languishing in the ED, waiting for a bed, actually, they didn't have to be hospitalized in the hospital. They could have been transitioned home to the hospital at home model, and those beds could be actually freed up. So it actually could help with the flow of patients into the hospital. Now, this study compared two groups of people, but the study did not include the oldest of old. But you can see here now with our young population, even those who were in the hospital at home model as compared to the inpatient model. So HAH is hospital at home, and IHC was the patients who had COVID-19 and who were hospitalized inpatient. Obviously, these are numbers from just one study, but we can see here that, the percentage, the length of stay was also measured, the length of stay due to pneumonia and ICU admission. Those who were in the hospital at home model had, significant less ICU admission requirement, also significant mortality decrease in the hospital at home individuals as well. But again, this was a study that I found, it was eye-opening. It didn't really include the older adults, excluded patients above the age of 75, who I believe can benefit the most from the hospital at home. And since I focus on older adults with cancer, this hospital at home care model is also being rolled out to cancer centers, such as Dana-Farber is very involved in this. Also, other places around the country, at least 5 centers so far have been identified in trying to now care for older adults with cancer at home, even providing chemotherapy transfusions at home if possible. During the COVID pandemic, I cannot tell you how many of my patients with cancer just dropped off the radar. They did not follow up. They did not even, follow up to get the biopsy. Chemotherapy regimens were halted. A lot of patients who I referred to hospice, didn't really have to go to hospice if they had maintained their care, but it was just so difficult with the pandemic. Transportation logistics can be extremely difficult. The reason why cancer studies, even clinical trials, are not available to older adults is because they just can't get to the clinical trial site. Something as simple as transportation has been identified by the National Cancer Institute as an obstacle for older adults to get the proper, treatment or to be even included in the cancer trials. Something that the cancer community is really trying to change. And what usually happens during the course of cancer treatment, beyond the chemotherapy infusions, is that we see patients going back and forth from the home to the emergency department. I'm at the hospital right now, and I just saw a patient who has been to the hospital 3 times this month. And at the early part of this month, in October, they were fully coherent. They were talking with the loved ones at home. And now, after coming back and forth, being treated with all kinds of different medications, some medications falling off, falling on, sitting in the bed alone, talking to nobody, pressing the button, and the nursing people come to address pain management maybe an hour later. He is completely delirious. And I just spoke at length with family members, and they are so beside themselves because now he is having the classic delirium, which we notice is higher in older adults who get frequently hospitalized. And there's a wide variety of causes for that, but that's another lecture altogether. So, for example, intractable pain or pneumonia from impaired immune system by chemotherapy. That's why we see a lot of patients come from the home to the emergency room. They have intractable nausea, intractable pain, and they just sit on the gurney in the ED, waiting and waiting. And when they finally get admitted, their older spouse is sitting on a chair in the hallway. She's exhausted. Everybody's just miserable, and that's a recipe for more delirium and just a vicious cycle.
The Zoom thing.
So,
Teacher sent.
and also, like we said with Italy, they're at a higher risk.
Sorry to
of
interrupt,
hospital.
Imran. Sorry, please mute yourselves. Sorry, Imran.
No, it's right. They're at a higher risk of hospital acquired infections, and hospital acquired infections are a huge problem. I've had patients come to the hospital with a UTI and not leave the hospital, die from a nosocomial infection. So it's very important. So this is from a very recent article about how a group of oncologists are envisioning how the oncology hospital and home model can really work, which including, home care, skilled and unskilled nursing, also inpatient care, which can be provided at home. We can do a lot of things at home. We can even do x-rays at home. I have a portable handheld General Electric ultrasound that I'm learning how to use, but I can, instead of dragging them to the ED to get a chest x-ray, I can look for pneumonia while somebody's sitting on their recliner, on their lazy boy with the ultrasound device. There's so many things you can do now with technology at home that you don't really need to always drag them into the emergency department. And, even outpatient care, we can send a phlebotomist at home to draw blood. So there's a lot of things we can really do to improve the care at home. And this is the article where I got that image from the oncology hospital at home. And, it's really, it's showing good results, shorter length of stay, lower rates of readmission, and Mount Sinai, of which I just graduated from and will be starting as a junior faculty next month, they have been a part of this hospital at home movement. And I'm going to show you this 2-minute video, which talks about what Ronnie talked about and how partnerships are being formed between hospitals and health organizations and these billing agencies, which can help navigate the very confusing process of billing for hospital at home care. So let's just watch this if this works.
MAC stands for the Mobile Acute Care Team, and that's what we call our hospital at home program. We're really replacing a hospital admission. Most of our patients meet us in the emergency room when the emergency room doctor has determined that they need to be admitted to the hospital. And then we come in and offer our services instead, where the patient comes home with us and they have doctor's visits, nurses visits, oxygen, IV antibiotics, oral antibiotics, everything that they would need in the hospital, labs, x-rays, ultrasounds, and we do all of that at home.
We've seen overstay patients since the program's inception. Over that period of time, the readmission rate to the hospital has been cut in half. Patient satisfaction outcomes are about 20% higher, and the overall cost of delivering the care is 20 to 30% lower. And one of the things that's been a challenge for other organizations that have had programs focused on hospital level care at home is the integration of the clinical, the operating, and the financing model. What's unique about where Mount Sinai is going is we've actually found a way to create a payment model around that. And we've been testing that through the prior demonstration. Contessa has built an entire business on figuring out the payment and the operating model for hospital level care at home and how that ties to the clinical model.
The goal of our partnership was to combine our areas of expertise and enable to make this program available to any patient that has commercial insurance or Medicare Advantage coverage. No one is really focused on how to deliver hospital level care in a different manner. And that's exactly what our partnership does. We're reinventing the care model. Not only are we delivering care differently, but we're also being reimbursed for it in a different manner. We receive a prospective bundle payment. So that's one lump sum payment upfront. And we in then turn pay all the downstream providers from that payment.
Here at Mount Sinai, I hope that we're going to be able to offer this to all the insurances that Mount Sinai takes. But in addition, we'd like to be able to stand this program up all over the country.
So that's just one example of one health system, but as Ronnie said, there are so many health systems out there. And now to, segue into Carol's segment, what does this mean for caregivers? I've actually spoken to a lot of caregivers, and I was recently at the American Society of Clinical Oncology Palliative Care Conference in Boston. And I spoke to a caregiver who told me how her husband, who had pancreatic cancer, was in and out of the hospital. And it actually stressed her so much even limited life that he had was spent in the emergency room. And she is a strong advocate for this care model and spoke on the panel there on how she and her husband could have enjoyed that time with loved ones and family in the comfort of their lovely home, which they built. And instead of spending all that needless time in hospitals and in doctors' offices. So it really is a quality of life issue, and caregivers really, really need that. Really appreciate this. I mean, 2.8 million caregivers for patients with cancer in the United States, and that number is rising. And hospital at home, you are actually in the home with the caregiver. You're able to give them instructions inside the home setting on how to deal with symptoms in the middle of the night. You know, your loved one is, needs to go to the bathroom. Well, here is the bathroom. You get to see the actual environment. It makes such a difference doing that in person rather than just handing a printout when you get discharged, which really means not much to the caregivers. So it's really the bottom line is the hospital home model is going to be the new uncharted frontier when it comes to the current landscape of acute care delivery. The payment models and providers are not fully on board. A lot of doctors I speak to don't like making house calls as they feel this is like making house calls. Even the lay public underestimates the great resources. They think, well, I need to be in a real big hospital so I get all the best care. They don't understand that, all the best care can indeed be provided at home in some cases. And for the older adult with cancer, the prospect of avoiding hospital admission can really be, very beneficial. And, with that, I'm going to pass it on to Carol, who will talk about caregivers and their perspective, because it's, really, really important.
Thank you, Dr. Ali.
God. Yes. Thank you. Oh, I've learned so much from both of my colleagues. And Imran, I want to get a tutorial on inserting all these wonderful slides and videos. I am a senior fellow at the United Hospital Fund. I don't really know what that means, but I think it means you're not working here anymore, but we still want to call on you to do things. Oh, that's fine with me. I love it. Next slide, please. The United Hospital Fund, for those of you who may not know, is a 100 and something years old. It's been working in New York City, but it's also in New York State, and for certain projects, like the ones I've worked on nationally and even internationally. It's an independent nonprofit organization that does a lot of analysis, a lot of convening of groups to find better ways to provide care. Next slide. What I want to do in the short time we have here is a little bit about who are family caregivers and what they do, and then two sets of recommendations. And these recommendations are based on a blog that Ronnie Snyder and I published in the Health Affairs blog in June. One of the set of recommendations about what hospital at home clinicians can do to prepare and assist family caregivers. Because what Imran says is absolutely right. Families don't like hospitals anymore than patients do. And that's partly because they're not treated very well. You think patients are ignored. Try being a family member in those situations. But also we wanted to talk about in our blog what leaders can do to enhance the services, develop research programs, and advocate for services for patients and caregivers. I was thinking I was a family caregiver for my late husband, who was in an automobile accident. I was there too, but I was not hurt. He had traumatic brain injury and was left quadriplegic. And so I took care of him at home after he went through gained consciousness and went through rehab. And the first article I wrote was called Home Sweet Hospital 30 years ago. And that the idea was that we were doing the hospital things at home, but there was no support. There was no program that supported us. Doctors did not want to come and see me. Anyway, so this is what we're going to, and there's one page of caregiver resources. Next slide, please. Who are family caregivers? I think it seems to me that everybody I know is a family caregiver of one kind or another. 53 million Americans, and they range in age from youngsters, and I'm talking about teenagers or lower, tweens, to older adults, sometimes older than the patient. They're all ethnic groups, all economic statuses. This is part of our world that has assumed that families can do all of these things. And many times families want to do these things. This is not something always that's forced on them, but without a lot of support. They're not necessarily, and these are the legal kinds of things that get in the way sometimes. Healthcare proxy, power of attorney, financial power of attorney, or next of kin. And in a hospital setting, that can become a matter of some dispute and some aggravation. I have been contacted by a man I've known for a while in California, going through a horrendous problem with a family member who has power of attorney and has healthcare proxy, but refuses to give any information about his father to the rest of the family. So a lot of the things that we read about and see about, including in the hospital at home programs, is about the emotional support and the companionship that hospital at home allows patients and families to be together, watch TV together, talk together. All of that is critical, but that is not the only thing that family members do. And if you look at the family caregiver literature, it always seems as though ADLs, activities of daily living, instrumental activities of daily living, managing bills and house care and all of that, they're important too, but those are not the only responsibilities. And I'll just go on a little bit about that. Caregivers are mostly unpaid. There are some ways to get paid, but you really have to work at that. And they have limited access to training, support, and respite, which is really important. And again, as has been mentioned, COVID has exacerbated loneliness and depression in both patients and caregivers, and it has led to considerable financial hardship as people have lost jobs, have had to go to are not able to continue to work. So we're in a bad state in terms of what is available for family caregivers. Next slide. I did some work with the AARP, and that may have been funded by John Rainford, I'm not sure. I don't remember. We did a national survey of family caregivers, asking about what they did, ADLs, IADLs, and something we called medical nursing tasks: medication management, wound care, operating equipment, monitoring changes, being the one who talked to the professionals. And those were all reported in 2 reports. One was called Home Alone. We're good at titles, Ronnie. And the second one is called Home Alone Revisited. And next slide, that will show you. This is a Home Alone Revisited. And that's a kind of an eerie photo of eerie drawing, but that's kind of the way you feel. You can be in an apartment building in New York City, and yet you feel as though no one else is ever there. So the 5 major findings were that today's caregivers provide intense, complex care, and they do manage multiple health conditions that are often accompanied by pain. And yet many caregivers are still on their own. So health system should do more to prepare these vital members of the team. And they those people who perform more medical nursing tasks experience both positive and negative impacts. And I can support that in that everyone who said to me, why don't you just put your husband in a nursing home? You can't go on like this. I said, I am doing this because I love him and I will keep him at home. But it was really, really, really hard. Next slide. So what can clinicians do? As part of the enrollment process, the patient is asked whether family members are available to help at home. And sometimes the patients say, yes, my wife will do it. She does everything anyway, or my daughter can do it. They very rarely say my son, but that's not true. The sons do quite a lot. But the patient may say no one is needed. What does that mean? It may mean a reluctance to be a burden, so-called, burden on the family. A lot of it means a fear of losing independence. If you say, I need help, a lot of older people feel that that means that you're going to lose all control of your life. So I think it's really important for the clinicians, if you hear those terms, if they hear that reluctance to involve the family member, to explore the meeting and say, well, this is just, this can be temporary. If you can bear with your family helping you for a few weeks, you'll probably be able to be as independent as you were before. Or if not, then you figure out what they can do. But it's also important to ask the caregiver what they do and who helps and what that person helps doing. Ask who lives in the home. Are there children in the home? A lot of families are multi-generational now. So there are, the older spouse, the older parents, their children and their children's children, and then often other relatives who somehow got brought into this household. So that can be a help, but it also can be very confusing, and it also can create a lot of dissension about whose job it is. Does the caregiver have a job? That's really important. What is the impact on the employment? Can that caregiver take time off from work and be available when the doctor, the nurse, the technician, all of those people are coming to help at home, in hospital, at home? There should be someone there really to make sure that all of the questions are asked. Not all patients are as good at asking questions as some. So the employment is a real issue. I think it's revealing to find out how long the caregiver has been involved in the patient's care. For some caregivers, they know as much about this patient as any professional does. They know what they've been through. They know what medications they've been on, why they're not on them now. They know, they have the history. But a new caregiver, if this is the first episode or one of the first episodes, they are really not well trained, and they may need more training than the one who's been very experienced. So there are a lot of things that clinicians can do to make the family caregiver a better caregiver and a more comfortable caregiver. Next slide. There are some other things here. I forgot about this. They can help prepare family caregivers for what is going to be provided at the hospital at home, and what the caregiver should really do to be present when the staff come and go. There's extra laundry, there's preparing meals if they're not supplied, and reporting to staff. And so that's that beginning phase. What's going to happen? What do I need to be able to do? And then the second phase is to prepare them for discharge from hospital at home, which is not, this is not a long-term service. This is a relatively short term. So you're already thinking about what's going to be happening once the hospital at home is gone, and prepare them for the next phase of care. So hopefully they will not have to go to the ED again, and their care will be continuous. Next slide. Now, hospital and home leaders can do a lot too. They can create tools for the hospital website or brochure for the emergency department that explains what their program provides and who is eligible and what it means. And there could be a template developed for that, but each hospital, each site will have specific information and what to do about it. I suggest that a health literacy expert review the text. We at the United Hospital Fund, we had a whole series of guides for family caregivers, and I'm a writer. And I think I'm a pretty good writer, and I'm good at getting jargon out of the way. But when we had a health literacy expert review the text, she always found something that I had brought into language that was fine for me, but was not really something that an ordinary person would know. So that's a very valuable way to improve the text. And I think it's really important to enlist family caregivers who participated in these programs to review the assessment and other tools for relevance, language, and clarity. And that could be part of the Family Advisory Council if there is one in the house, in the hospital, or it could be a separate group. Creating an up-to-date list of local community resources for both patient and the caregiver is very helpful. There may be one, but often it's not up to date. Review the CARE Act for the state. That's a state law. It's state law in New York and 34 other states that requires the hospital to act on admission whether the patient has a family member who is allowed to receive medical information. So what applies? This is not in the hospital. So what applies, what doesn't, and what's good practice, even if the CARE Act doesn't apply legally? That really requires some attention. Next slide, please. All of these items are about what leaders can do as a group, working together through the users group or any other way to add family caregiver items to the research agenda and add items to the users group website. And qualitative studies, I think, can be very helpful. Finding out what works best for the caregiver, what adds strain. Sometimes medical equipment is intrusive. It feels intrusive. Having many people come and go, as much as you are glad they're doing this job, how does it interfere with the daily routine? Find out what life is really like for the caregiver as well as the patient, and include these items as well as patient-centered outcomes in evaluation project. I think it's not enough to say they're satisfied. What do they love? What do they think could be done better? That will be very valuable for the future. Next slide, and I think that may be the end. And here is some resources that you can look at and find some assistance for family caregivers. There's a lot out there, and a lot from disease organizations too, but these are sort of basic resources for family caregivers. Final slide. Thank you. And you can reach me at this email if there are further questions. Thank you.
Thank you, Carol, and thank you, panel.
Really terrific presentation. My only complaint is too short. I wish we had 3 or 4 hours. So we're ready to take questions, and if I could be allowed to ask a question, and I'll just open up to whoever wants to answer it. It seems that the HAH model is mostly about older people, and is that because of the CMS waiver? Imran cited a couple of studies. I think one was Spain, where they had younger people involved. But in the US, I think because it's a CMS waiver, is that right? It's mostly older patients?
I'll start. There are, as I mentioned, there are a whole host of hospital at home like models, and some of those are pediatric, it's true. In this country, the work that I've mentioned began really out of the geriatrics division at Johns Hopkins University, and with support from the Johnny Hartford Foundation, which has the Aging and Health program that I referenced. It has focused a lot on older adults. It is not strictly older adults, but you're correct in what you're hearing.
But it could, Medicaid is also part of it, right? I mean, it's not just Medicare.
The waiver, as I understand it, is for Medicare.
Not for Medicaid?
I am less familiar
Okay.
with the Medicaid side of that.
Yeah, I guess you're right.
Thank you. Yeah, so would it, I guess it would be difficult because of a younger population would have private health insurance, maybe through an employer or
Should
something.
not. I mean, it should not. I mean, I've taken care of kids with cerebral palsy because I did palliative care fellowship where we do palliative care for kids and adults. And it's just it's such a chore to take them back and forth, you know, with the disabilities that they have. So I believe the hospital at home option is also being revisited for those with disabilities, including children with cerebral palsy and other disabilities. Correct me if I'm wrong.
No, I think that's fair. And I mean, there are also contracts to provide hospital at home. So part of the, you know, I mentioned earlier the hospital at home users group, and one of the things that they work on, that they help those who've joined the users group with, is figuring out these billing issues so that it's not strictly Medicare, for example, but that there are other populations and other forms of payment for this service.
And that's what Contessa Health is doing with Mount Sinai. And they describe that, yeah. There are definitely still a lot of obstacles at that conference for the American Society of Clinical Oncology. Billing is still an issue. There's, you know, if we provide all the hospital care at home, then the hospitals are not going to be too happy. So there is some pushback from them as well. So it's still it's hard for everybody just to accept change. Shifting paradigms takes time.
Hospitals would be happy if it reduced readmission rates, right?
True.
Which you pointed out. But it is the hospital at home model more expensive as the same care provided in a hospital?
No.
Not at all. Because it's at least 30% cheaper, because, you know, just the room itself, you know, there's just so much other costs that we don't think about. The pharmacy, I'm sure there's an economist on the line here. Maybe you can help me out. I mean, just the hospital stay is not only just the treatment and the nursing staff. There's a lot of other variables that add to that cost.
That's all the things that families do, which don't cost anything.
That's right.
Right.
And then you're not paying the same level of the infrastructure. But I will say that I showed a slide with some of the sort of what makes this a proven program. And one of those bullets is about lower costs of care. And that's of great value to many payers and especially value-based payers.
The chemotherapy, a lot of people are worried that, you know, what if there's an acute allergic reaction in the home? I don't want to transfuse chemo in a home. They have to be at a chemo infusion center. But a lot of my older adults, it's just so hard for them to go back and forth all the time. You know, and this was just so depressing that none of them really enroll in the clinical trials because of obstacles such as transportation. I mean, that should be, I mean, isn't there like an Uber service that can take them, you know? I mean, that shouldn't stop somebody from getting, you know, enrolling in a clinical trial, which could potentially extend their life by a month or two, you know, just to help them with the cancer treatment. But, you know.
And if they don't have someone at home who can help, a caregiver who
Yeah.
can help, then they might not have that choice to do a hospital at home.
And Ronnie, you brought up that cat. I had 2 patients who wanted to walk against medical advice because they had a pet at home. And
This is real
they
life.
would take, it's real life. They would just take their IV and I have to go, you know?
Hi, this is Cindy, and sorry I came in late to the presentation because I'm not sure if it was discussed, like, for instance, you know, if there isn't anyone like Ken is saying at home, and you know, there has been, especially with COVID, huge issues with trying to get good quality care for your, you know, loved one. And that becomes a huge issue. I mean, you know, they're either they're not available, you know, or they're calling up at the last minute. And, you know, if you're a person that works 9 to 5 and you have to be at work and you're counting on this person to come in, you know, all kinds of things can happen. So, so yeah, we do need more trained, I think, people to be out there helping for the elderly and sick people that we have.
It's so true, Cindy. And, you know, I've treated patients who were, you know, very, very poor and extremely, and then on the other spectrum, really rich, where they had, you know, private duty nurses and then 3 backups also, and they can call at any
Wow.
time.
Yeah.
And, you know, nobody has that kind of resource. And
Right.
then you have other caregivers who aren't trained properly and not patient with our dementia population. I can't tell you how hard it was to find just the right one who worked, because a
Right.
lot of them were just impatient. They didn't want to, they weren't flexible. And it's just, and these caregivers, they are true heroes, both
Yes.
family and non-family members, and they get paid so little.
So little.
And it's
Yeah.
just so important for us to really, you know, elevate them by giving them the reimbursement that they truly deserve.
Yeah, yeah, I definitely think it is a huge issue because, you know, they for what they do, they should be getting paid more, without a doubt, you know, and there are some that truly care and you can tell, and then there's others that aren't. And I think just in general, when it comes to, sorry about that, just in general, when it comes to, I lost my train of thought now with the telephone ringing, but yeah, it's a sad thing when you don't have, oh, what I was going to say is, you know, just I think in the general population, I see it every day. Okay. Not to get off the topic, but that people in general out there in the workforce or in customer service are not, they're not used to, or they're not, I guess, have the, you know, the sympathy, empathy, I should say, for the elderly people. You know, it's as if they expect them to be like a 40, 50-year-old, no, this, that, and the other thing. And I have a 90-year-old mother and I just shake my head like, whoa, you know, so yeah, it's very interesting how out there in the world, I think things need to change a bit. You know, everything's a .com, and not every elderly person is with the whole .com world. Yeah.
Well, I have a question. Maybe somebody can answer for me because I'm still confused. I get these requests for FMLA forms for caregivers. You know, how long can somebody get paid under FMLA? I mean, it's not indefinite. I mean, is it? And is that what the Biden administration is proposing in their infrastructure bill right now? From a health policy point of view, somebody can maybe help me.
I don't think FMLA is indefinite, but I don't know what is being proposed. I want to say you can get probably a good 6 to 8 weeks. I'm not sure, maybe more. But you also, you know, I think you're not getting full pay if you go out on FMLA. You know, if I was to
No,
go out
no,
on
you're not.
FMLA to take care of a loved one, I don't think I'm getting my full pay.
Well, most of the people who use Family Medical Leave Act are doing it because there's a new baby, an adopted baby or a new birth. There are state laws, and there's a state law in New York, and I don't know the details of it, but there's more, it was more intended for family caregivers, but it's short, and I don't think it's the full pay. It's practically very, it's difficult. And honestly, you know, a lot of caregivers, women, work in small, either businesses or offices where their absence actually makes a big difference. So there is something about, you know, keeping these small, often minority-owned businesses afloat. So it's not all that simple. It's different if it's you know, a mega corporation where they can't afford to do what needs to be done. Not everything is like that.
My understanding is that the federal FMLA provides for unpaid leave, a job protected unpaid leave. So if you have to provide care, usually for a kid, you still have your job, and states differ, and companies may also have their own policy. But yeah.
Sorry. The only thing I would add to that, and Carol touched on this, is that Family Medical Leave Act kinds of leaves, they're short term, you know, they're not long term. So it's not for the kind of caregiving that many of us think of when we think of older adults. And it just doesn't lend itself very well. It's sort of a whole time off for a period of time that is short, as opposed to stretched out, you know, a period of some level of relief over a longer period of time.
Yeah, or episodic care. You know, when I was working full time, the 17 years I was a caregiver, and there, you know, for months maybe there'd be no problems, and then there was a hospitalization, so I needed 3 days or I needed a week, which fortunately my employer was very good about, but not everybody has that. And then you go back. So you can't always plan what's going to happen. So it's a tough situation, but it truly is one of the things that caregivers do. They suffer financially, they suffer emotionally from, because they have responsibilities that are divided, to say the least.
I do want to add.
Yeah,
Oh,
to add
go
on
ahead,
that,
Jay.
there are some students who are responsible for, you know, taking care of their loved ones. So they're dropping out. They're dropping out of school, where it has a huge
So
impact.
true.
Yeah, on their life.
I mean, I know our time is going to be limited, but I just wanted to add this one tidbit. There is a startup company who contacted me. I talked to the founders. It's called CareLoop. I don't know if nobody heard about it. It's an app and it's a service where they actually provide caregiver support. You download this app, and they have a panel of experts in providing resources for people at home. And it's just a very, very nice.
What is
startup
that
company.
called? What is that
It's called a Carry Loop. That's CARILOOP. And I spoke with one of the founders who met me on actually on LinkedIn. So there's a need, and people are knowing this. And I think a lot of the private sector and public sectors are going to really come together.
Well, one of the things that I've been working with a small group on is the development of peer support, as in behavioral health, which is not a friendly visitor kind of thing, but someone who helps you navigate the whole healthcare system and helps you get through, solve those problems. And it's been well proved in behavioral health, but not in so much in medical situations, although VA has a pretty active group. So that I always used to say, I don't need anything, but if you want to do something for me, make sure it helps because I don't need good words, or kindness. I just need help.
Thoughts and prayers. That's what I always hear.
So
well, we need thoughts and prayers, but we also need some other things too.
Yeah.
I think there's an app for that too. So we've got about a minute to our dead stop, and I'd just like to offer the panelists an opportunity to have some final words if you want. And thank you all, Ronnie, Carol, and Imran. Really terrific presentation.
Thank you.
So
Well, I just want to thank my fellow panelists. I mean, this is an exciting time for geriatrics, and I'm glad I picked this field. And not only because of the medicine, but also the public health and the policy issues that we can really initiate change. And we have a lot of work to do.
I agree with that. And despite my comment about how much more needs to be done, I just want to say I am very much in favor of hospital at home programs. In fact, my dear late husband, the last thing he ever said to me, I said, I have to call 911. You have to go to the hospital. I said, no, hospital. And that was it. So it's important.
Carol, that's your Back to the Future, I guess.
Yes.
So back to the name of this webinar today. I showed you that the Johnny Harper Foundation has funded this program for many years, and it has taken many years and a great deal of dedication on the part of, I mentioned John Burton and Bruce Leff, and also Al Su, and a number of others, Linda DeSherry, who you showed the video of, Imran. This is a program whose time has come. I'm really, really glad that Carol is laser focused on caregivers as a part of this and mentioned some of those Home Alone reports, because that shows not only how critical family caregivers are, but how critically important it is that we pay attention to family caregivers and support them. And that really encapsulates, I think, the point of this webinar and what I hope everyone will take away with them. The need for this program, service at home, is what we want. And to make that happen, we've got to support our caregivers.
Well, thank you so much. The recording will be made available on the Center for Long-Term Care website. And of course, I'll send that along to the panelists. Thanks again. Thank you, everybody, for joining us. Everybody be safe and stay happy.
Thank you.
Thank you.
Thank you.
Bye, everybody.
Bye-bye.
Thank you. Bye.